Okay, Bismillahirrahmanirrahim. Sorry for the delay, some sort of computer problem or network problem. So we start with further any delay. Topic today we will discuss is anti-diarrheal and antimicrobial drugs. This topic is basically divided into two lectures. So this is the first lecture in which we will discuss the antidiarrheal drugs, general treatment for the antidiarrheal drugs. And in this lecture, we will also discuss the protein synthesis inhibitor, which is in connection with this. Okay, so start. And in the second lecture, we will primarily discuss the anti-amoebiasis. I just want to give you a review that in for today's topic, we will focus on simply the diarrheal treatment and its its antibiotic and other things, whereas the second lecture mainly consists on amoebiasis. So, what is diarrhea? Everybody knows, most of you people know that diarrhea is an imbalance between the secretion and absorption of the fluid. So, excessive loss of body fluids through the GIT is known as diarrhea. So, the problem is that you are losing the fluid in which water is there as well as salts. So, loss of salts as well as the water from the body is the manifestation of the diarrhea. Treatment is simple, okay, regardless of knowing the cause. Okay, this is a very common complaint, and usually when the patient come in clinic with this diarrhea, if we are not going to do any investigation or we are not suspecting any infection, then the simple treatment of diarrhea is to just give you just have to refill the water and salts to the body. So you just have to replace this process, and this is known as oral dehydration salt. So this is a very common practice that we give a drug, or which is known as oral dehydration salt. It comes in the OTC, and this solution contains the water as well as the electrolytes like sodium chloride, potassium chloride, sodium. So it's a very balanced solution. It is basically it is made according to the osmolarity of the body. So it has a certain osmolarity. So this is simply whenever a patient comes with the complaint of the diarrhea, you just simply give him ORS, very well known, or oral dehydration salt, so that the loss of this water and the electrolytes will be replaced. Okay, other thing that you can do, right now I'm discussing the general measures of the diarrhea, how to manage a diarrhea. Okay, so generally, what are the drugs that are given? We are not going specifically, we are not going on to the cause, but we are just discussing what general measures you can do to treat the diarrhea or you manage the diarrhea. So first thing is to give the ORS or oral dehydration salt. Second thing, you can also give the anti-motility drugs. Okay, you know, the diarrhea is basically due to excessive or hyperactivity of the GIT or the muscles of the GIT or intestinal movement. So intestinal movement, if you slow down this movement, you can also reduce the loss of this electrolytes and the water. So reducing the movement or the motility, you can also control the loss. So anti-motility agents, what you have, you can have opioids. They are very opioids has a they decrease the peristaltic activity of the GIT, so they are commonly used. In the opioids, we have codeine, we have diphenoxylate, loperamide. This is a very common drug, loperamide. This comes with the brand name of Imodium, very commonly used by the people of patients, and they are very well aware of that. Whenever they have an episode of this diarrhea, they start using this loperamide Imodium capsule. So this is very common. So you can use or you can prescribe the drugs like morphine drugs, or opioid drugs like codeine, diphenoxylate, loperamide, opium tincture. Morphine is a very potent drug. Usually we do not use, but the two drugs are very common. This is the diphenoxylate and loperamide. They are very commonly. The codeine is also used. So you can the second way how you control the diarrhea or you can stop the loss is the anti-motility drug or stop the motility. Also, the third thing that you can do after rehydration or anti-motility drugs, you can also increase the viscosity of the gut content. Means the diarrhea is basically is a condition when the viscosity of this stool is very low. So by increasing the viscosity of this the gut contents of the stool, you can also stop the frequency of this diarrhea. So the agents that can increase the viscosity of gut can also be used, and in this category we use a drug like Kaolin Pectin. This is very common in the methyl cellulose and activated atropine. This is also used. So three classes you can discuss in the treatment: the ORS, oral rehydration salt, the anti-motility drugs, which basically consists of opioids, and you can also increase the viscosity, in which Kaolin Pectin is more important. Okay, another way of you can stop the motility. You can also use anticholinergic. It's not basically the motility. Anticholinergic are anti-secretory. So secretions can also be stopped, and they also reduce the motility of the GIT. Anticholinergic can be used, and in this class you have atropine. Atropine is a potent or parent type of anticholinergic drugs. Belladonna, this is commonly very common in the drugs like homeopathic drugs. They contain this compound, natural compound belladonna and products, so they are very good anti-secretory. Other, you can use mebaverine and other thing, but atropine can also be used as an anti-secretory, as an anticholinergic, to reduce the secretion, as well as they have also an anti-motility effect as well. As miscellaneous drugs, you can have peppermint oil and others, but these three classes you should know. So ORS, or rehydration salt, anti-motility drugs that increase the viscosity, and then we have the anticholinergic drugs. We will discuss a few points regarding these classes. For example, anti-motility drugs, that basically is opioids. How do they work? How do opioids reduce the motility? They basically increase the colonic phasic segmenting. Segmentation is basically a process which is reverse or inverse to this peristaltic activity. So segmenting is basically you are inhibiting the movement of the GIT. So they increase the segmenting process, and they act through the neurons present into the GIT. There are cholinergic nerves. You have a separate nervous system in the GIT, that is mesenteric plexus and mesenteric plexus. So they act on this plexus, and they basically inhibit the presynaptic cholinergic nerves. This is why anticholinergic nerve drugs are also important, that they also can reduce the motility. So opioids inhibit the presynaptic cholinergic nerves, and this is how they decrease the motility of the especially of the colon. And when the motility is stopped, the loss can be reduced. I told you the drugs that are very common in this category is one of the drugs is known as loperamide, which is, I told you again that this is commonly known as Imodium. We give you the brand, we tell you the brand name, because most of the time when you come across with your family or other people, because people suspect from you that you should know the name of the drug. So the brand name of the drug is Imodium, very common, and this is very much taken by the people as an OTC drug. So loperamide is commonly used. What is good thing about loperamide, that it when it is given, it has a local action. It is usually not very much absorbed from the GIT, and even if it is absorbed from the GIT, it does not cross the blood-brain barrier. So the side effects of opioid, that that opioid effect on brain, and you have a addiction tendency. So loperamide is good in a sense that first thing that it is not very much absorbed from the GIT, and if it is absorbed, it does not cross the blood-brain barrier. So the side effects are basically are not very common with this drug. Although tolerance can be developed, people using for a long time. So in the starting they have a good effects, but they complain that okay, nowadays when we take this Imodium, the effects are not as that for the previously. So 2 milligram Imodium capsule is given, and it can be used 3 to 4 times daily, and this people really use to reduce the motility. Second anti-motility drugs or opioid is diphenoxylate. This is also a good drug with the opioid, but the negative point from this is that it has the CNS effect because it can cross the blood-brain barrier. So difference between loperamide and diphenoxylate is that loperamide do not cross the blood-brain barrier, whereas diphenoxylate is an opioid which can cross the blood. Although the high dose is required to have CNS effect, and the drugs that are made they are prepared for anti-diarrheal treatment, they have a very low amount, or they have a very low potency. So if it is used in a small amount or low doses, it do not have usually the CNS effect. The cut point or the maximum dose you can use is 2.5 milligram. So your dosing should be less than 2.5. Otherwise, if the amount or the dose is more than 2.5 milligram, it can have this CNS effect. Another thing that you can do with the diphenoxylate is that you can also add atropine with it. Okay, atropine is basically, we combine this diphenoxylate with the atropine because atropine is the competitive inhibitor of the diphenoxylate. So if the dose is over range, or it is producing the effects, the atropine is combined with this in a dose of 0.025 milligram. The ratio is 2.5 milligram is diphenoxylate and 0.025 milligram atropine. So atropine is added to mask the side effects of the diphenoxylate because it is a competitive inhibitor of diphenoxylate. Also, atropine, we just discussed that it can also have an anticholinergic activity, so it can also have a synergistic effect or additional antidiarrheal effects. The first is loperamide with no CNS effects, no side effect because it does not cross blood-brain barrier. Diphenoxylate is a good one, but it can have CNS effects, so the dose should be reduced, or you can add atropine, which is a competitive inhibitor of this drug. Okay, Kaolin Pectin, we just described that it is basically a drug which increases the viscosity of the stool, so that the frequency of this loss can be reduced. Kaolin Pectin is a combination. Kaolin is a salt, hydrated magnesium aluminum silicate. It is a salt, and pectin is basically an indigestible carbohydrate. So this two combined together, and they both are basically adsorbent or absorbents. So they given so neither not only they increase the viscosity, but they also absorbs the toxins like bacteria and other thing as well. So it has a good impact that it increases the viscosity as well as it absorbs certain toxin and harmful substance from the GIT. Okay. The combination of this drug is known as kaopectate. This comes, and the dosing of it is usually used in around 1.5 milligram. Why dosing is important? Because you can use these chemicals with a certain range. Overdosage of these chemicals can lead to problem in the patient. So maximum 9 gram can be given, means you can use 4 or 5 sachets of this chemical, not more than this, otherwise it will cause the problem. Okay, what is the precaution when you are using antidiarrheal agent? Remember that antidiarrheal agents are not usually the first line agents to be used. Most of the time a good clinician is one which basically keep the patients on rehydrating. Like you start treating the patient with the rehydration, like you can give orally ORS, or if the patient is not responding or is unable to tolerate this oral salt, means he or she can have the vomiting or emesis, then you can start giving him the IV fluids. So the first thing is that replace the fluid either with oral if there is no vomiting, and if there is problem with the vomiting, then you start giving him with the intravenously or IV. The first thing is to give through replacing the salt and water. Second thing that you can also do with the anti-diarrheal agents with anti-motility, but remember that the precaution in this that if you suspect that the patient has any bloody diarrhea, stool in the blood, blood in the stool, and then you have a high fever or you suspect some other thing like systemic toxicity, so never give this anti-motility or the drugs that reduce the motility. Otherwise there would be complication like patient come in the hospital, especially in our government hospital when you used to do this house job, we see that they have a distended abdomen, and the thing is that they start keeping this anti-diarrheal too much, so this blocks the GIT, and when this motility is stopped, there would be the abdominal distension, which is another problem for them. So anti-diarrheal or anti-motility agents are not commonly used until unless a clinician decide, okay, you can add some extent of this anti-motility drugs. Rehydrating a patient is the safest mode, and the good thing to do with him, it doesn't have any harm to the patient. Okay, so this is something of journal measures. Now in the second part we come after managing a patient. If you manage a patient for 2 or 3 days and after rehydrating him there is no response, the diarrhea frequency is the same, then you come with the cause of the diarrhea. You have to know what is the cause. So better to find out that what could be the cause. So infection is the most common part. First thing that there would be an infection with the enteric organism. Okay. The second thing, for infection we will use antibiotic, and that we will discuss in the later part, what antibiotic you suggest in the case of the diarrhea. So infection could be there, a GIT infection, enteric organism. There could be inflammatory bowel disease, IBD. It's another condition. You have to rule out whether it has any inflammatory disease of the gut or bowel. There could be a malabsorption syndrome. There could be disorders of gut motility. There could be secretory tumors. They are also common. And when the complaint is long, usually what we used to do in our hospital setup, I mean, we were practicing, it is said that you treat the patient, you treat the acute diarrhea with the replacement of the fluid or antibiotics. But if the condition persists more than 15 days or 2 weeks, then we declare it as a chronic diarrhea. In that case, then we rule out this secretory problem, secretory tumor, any inflammatory condition. Usually, we do not investigate it within first week or 4 or 5 days. If you start investigating, or you're doing any colonoscopy, rather, this will give burden to the patient. You treat the infection in the first week with the replacement of the fluid, any anti-motility drug, then with the antibiotic. But if the condition persists for more than 2 weeks, then you go for the different, the diagnosis goes towards the other causes of the diarrhea. So we will first discuss the infection, which is more related with today's topic. Infection could be of different organism, but normally 2 or 3 conditions that we will discuss today. One of the conditions is known as cholera. Cholera is a severe condition or the severe diarrhea, which can lead to fatal or can cause the death into the patient. And for the cholera, the organism or bacteria is there. The drug that we use for this condition is, for the younger children, we can use this macrolide group erythromycin, or for the adults we can use tetracycline. So the topic today that we are in coordination with this anti-diarrheal, and you will see protein synthesis inhibitor. This is because the management of this anti-diarrhea, although there is a variation, you can give different antibiotic in diarrhea, but generally the first line therapy that we use to treat with the diarrhea condition, we give the tetracycline group of protein synthesis inhibitors. Protein synthesis inhibitors are generally given. In that case, we have erythromycin and tetracycline. This is a drug of first choice, or you can use cotrimoxazole. Shigellosis and other condition we also use. So we will discuss today the protein synthesis inhibitor. The second part that I told you, this is intestinal amoebiasis. This we will discuss in the coming lecture. This is basically anti-amoebiasis therapy. So your topic, this antidiarrheal and antimicrobial, is divided into general measures of the treatment of the diarrhea. Then you have the antibiotics, in which we combine this protein synthesis inhibitor. And in the second lecture, we will discuss the anti-amoebiasis, because I am telling you, because this will not confuse you, that I have shown you in the slides drugs but didn't mention in the lecture. So drugs like protein synthesis inhibitor are of our target. What is a protein synthesis inhibitor? This is something sort of repeat you, because you have gone through with this antibiotic therapy, but we will go through so that you have a revision. Protein synthesis inhibitors, you know, they have a long class. They are the drugs that basically inhibit the synthesis of the protein of the bacteria. And in that case, we have the tetracycline, aminoglycosides, macrolides, chloramphenicol, and the newer drug is oxazolidinones. These are the new antibiotic introduced as a protein synthesis inhibitor. And in that slide, I give the bold having of tetracycline. So we will more focus on some features of the tetracycline, because this is a part of the lecture. So otherwise you cannot cover this whole antibiotic in a single lecture, because all antibiotics, they have a different clinical use and also their side effects. So we cannot do all these things in a single way. Okay, so tetracycline we will focus, and we will share some points with you. Tetracycline are the compound, they were first introduced in 1948. Tetracycline are basically, you know, protein synthesis inhibitor are divided into two classes. First is known as 30S subunit inhibitor. They act on bacterial ribosome. Ribosome have two parts, 30S and 50S. So these are the drugs that basically we inhibit the or the effect on ribosomes of the bacteria and the 30S part of the of this bacterial ribosome. So they affect on 30S subunits, and this is how they basically stop the translation process. You know, the protein synthesis is a different step. One is messenger RNA, then there is transcription, and then finally is translation. So translation process, which is done in the ribosome, this can be inhibited, and the final protein or the toxin that is produced by the bacteria can be stopped. So they are bacteriostatic in nature. You know, antibiotics are classified as static as well as lytic. So they basically stop the growth of the bacteria. Tetracycline have different variants. Like the main names are chlorotetracycline, oxytetracycline, tetracycline itself, methacillin, doxycycline, minocycline. So they are 4 or 5 analogs of this tetracycline drug. Little about their kinetics. Tetracycline is its absorption is goes 60 to 80%. The best one is the minocycline with 100% GIT absorption. All they are affected by the dairy food. So whenever you prescribe a tetracycline to any patient, always tell him or counsel him that do not take any dairy foods with this drug, because this is a very common habit of our people or our region, that they say that antibiotics are very warm, what we call it in Urdu ki dawaein garam hoti hain. So they usually keep taking milk along with it, so that this warmness or this heat that will be produced by the antibiotic, they can be reduced. So this is not a right phenomena. If you take any milk product along with this tetracycline, this will decrease the absorption and the effects will be reduced. From the distribution point of view, they distribute throughout the body fluids, especially teeth, bones, placenta, and they cross this. So there are side effects of tetracycline also on bone and teeth as well. You know that always remember that whenever you are discussing with the antibiotics, remember the main side effect of the drug. Not all this always diarrhea, vomiting, and this thing, but always remember the main side of it. This is usually also asked in the Viva exam. We expect you to have a main side effect of a drug. For example, whenever we ask you about this tetracycline, you should know that the teeth calcification, the problem with the teeth and bones are there. So we expect you to give an answer like this. So when we ask what is the side effect of tetracycline, you better to answer regarding that it has a teeth enamel problem, it has bone problems. So this is minocycline is the best drug to penetrate CSF. So condition of where the CNS is involved, so minocycline is a good drug. Two drugs, remember that doxycycline and minocycline, they are excreted or eliminated through the GIT. So again, if you think about in this scenario, the anti-diarrheal, doxycycline and minocycline are effective in anti-diarrheal because they are route of elimination through the GIT. So they basically remain more in GIT, and so they have a local action. Doxycycline is usually very much prescribed by the physicians for the as an anti-diarrheal. Doxy capsules are very common. They were commonly used. Nowadays we have a new generation, so we do not go. But if you remember one drug for the GIT infection, that is doxycycline. These are the other uses of the regardless of the topic that we are discussing, the anti-diarrheal. The tetracycline can also use for the Lyme disease, mycoplasma, Rocky Mountain, acne. So these are the conditions. But what I'm trying to focus here in the slide, as I'm telling you, that cholera is a condition which we just discussed, and in this case, doxycycline has a very good role. So in children we use erythromycin, and then in adults you can use the doxycycline as a good drug or first line agent for managing this cholera or diarrheal condition. What are the adverse for tetracycline? They cause GI discomfort, hepatic injury, nephrotoxicity. It also causes a nephrotoxicity known as Fanconi syndrome. Is basically infection of the renal tubules, so they also causes this as well. And again, they also cause the discoloration of the enamel of the teeth. I just told you that their absorption is very high in the bone and teeth, so if they are used for a long time, especially in the children, they come with a discoloration of the teeth. So whenever there is a discoloration you see in the teeth, your mind goes towards that he or she might be using this tetracycline group. Depression of bone growth, again they are deposited into the bones, so they can also be caused the stunt growth, not for a long time. Photosensitization is also another side effect. People complain with this skin burn or sunburn, and prolonged use can use to be as a super infection. Vestibular dysfunction in the air. Minocycline can also especially causes the air problem or hearing loss or dizziness, and you know that the inner ear is responsible for hearing as well as for the balance. So dizziness, vertigo, and this or tinnitus may occur because of this minocycline. Also, doxycycline also have this vestibular dysfunction effects. Okay, so we just discussed the tetracycline in the scenario of as an antibiotic. Although remember that nowadays the antibiotics for diarrhea is very vast. They are using different new regimens for this. Okay, there are some conditions which are not due to infection. The diarrhea which is not due to the infection. The special condition could be traveler's diarrhea. They could be drug-induced diarrhea. It could be secretory diarrhea or carcinoid tumor. So I again told you that we categorize the patient in such a way that we treat the patient for 2 weeks for any antibiotic therapy, for fluid replacement. Once we find out that the condition is not going to resolve and the patient is persistently complaining of the diarrhea, then we declare it as a chronic diarrhea, and then we start sorting out what could be the problem. So one of the reasons is the carcinoid tumor or lipoma, vasoactive intestinal peptide is a condition. So I just discussed a few slides about this secretory diarrhea or carcinoid tumor. The drug that we use in this secretory diarrhea or carcinoid tumor or vipoma is one of the drugs is octreotide. Octreotide is basically a synthetic somatostatin. What is somatostatin? Somatostatin is basically growth hormone, inhibitory hormone. So somatostatin, a 14 amino acid peptide, which is released from the pancreatic cells, and this because of this pancreatic carcinoma or any other condition in the pancreas, this condition develops that it starts secreting this the vasoactive intestinal peptide. So pancreas has problem, it is releasing too much amount of this VIP or vasoactive intestinal peptide. This is causing secretory diarrhea. So if the condition is any tumor, otherwise this is a different management that you eliminate this tumor, whatever the management. This is a different thing. But for the time being, if a patient has a secretory diarrhea due to high level of this vasoactive intestinal peptide or pancreatic overfunction, then you can use somatostatin. Somatostatin analog can be used because it can reduce this the diarrheal condition, or basically is the inhibitor for this peptide. Octreotide, again told you, is a synthetic octapeptide, and it can be given intravenously or it can be given as subcutaneous injection, 6 hourly or 12 hourly. And so this is a condition when you see that the diarrhea is due to some sort of tumor of the pancreas or other thing, then it can be used. Somatostatin, how it works? This hormone has a different action. It inhibits various neurotransmitters or the neurotransmitter hormones, like it inhibits gastrin, cholecystokinin, glucagon, insulin, pancreatic polypeptide, and again mainly is the vasoactive intestinal peptide. That is the cause of this secretory diarrhea. So it inhibits these transmitters, and they are the cause of secretory diarrhea. So it can reduce the intestinal fluid secretion and the pancreatic secretion. So remember this somatostatin as a drug for secretory diarrhea. The clinical use, I just told you that carcinoid tumor, vipoma, a surgical condition known as vagotomy when you remove or dumping syndrome when you remove the stomach. People have the GERD condition, gastrointestinal reflux disease, in which you surgically remove the stomach. They also complain of this secretory diarrhea. Sorry, not secretory diarrhea, the other diarrheas. So in that condition, you can also use this pancreatic fistula. So any surgical condition or any tumor condition, octreotide or somatostatin you can use. The last slide about this diarrhea is this. One of the common reason of this diarrhea is rotavirus. Rotavirus is also leading cause of mortality and morbidity in children. In pediatric practice, they know that the children come with a chronic diarrhea. Most of the time, the cause is the rotavirus. So, although we do not have a special therapy for the viruses, but some are the drugs that are effective against it. For example, if the cause is the rotavirus, then a drug known as nitrogenite. Okay, the nitrogenite is basically a drug that is coming. Also, this is it's a broad spectrum antiviral drug, and this drug can also be used. It's oxazolidones. Okay, this is chemically belong to this. So this drug can be used to stop this chronic diarrhea condition, and usually we give this drug to control this. So today's lecture is, although we are short of time, so I had to complete it quickly. The main thing that you have to remember is that we discuss in today's topic is that the general management of the diarrhea. What are the general management of the diarrhea that we discuss? The ORS, the other salts. Then we discuss the anti-motility drugs, in which we have opioids, and mainly the diphenoxylate and loperamide. Then we have the drugs that increase the viscosity, in which we have kaolin pectin. Then we have anticholinergic drugs like atropine, one of the drugs, and atropine is also used in combination with the steroid, so that we have a combination of atropine and diphenoxylate that I told you. They are coming in the combination. In the opioid, important thing to remember is that loperamide is a drug that do not cross the blood-brain barrier, so it has a less side effect. Diphenoxylate can cross, but the dosing is important, and also we use atropine along with it, so have minimize the side effects. Kaolin pectin, I told you, it increase the viscosity. Then we come to causes, and the causes we discuss the infection and the secretory diarrhea. Two things we discuss, the infection, because the other thing we'll cover in the IBT. This is a separate topic, and so we cover with the infection. And in infection we discuss mainly the protein synthesis inhibitor, and further discussion was on protein synthesis. And in the protein synthesis we focus on tetracycline and the different properties of tetracycline. And finally we discuss that secretory diarrhea, which is a special condition, and in which we use the somatostatin or octreotide, which can be used because this is of the it's a hormone, or it inhibits this growth hormone action, and it affects on various neurotransmitter as well. And the last slide was about rotavirus, and the drug was nitazoxanide, which is a broad spectrum antiviral therapy. Okay, although we can use the forum to have questions, but I see that the time is almost 2 o'clock, so probably we don't have a time to discuss. Tomorrow morning I have a lecture. Just after this 9 o'clock we will discuss the second part that I discussed, the anti-amoebiasis. I will try to cover up your questions regarding this in this class. Okay, so if you have some question, you can write it down somewhere. Hopefully I'll try to come early and complete the lecture within time, and then we can discuss any queries regarding the whole antidiarrheal topic. Today we discussed the part 1, and tomorrow we will discuss the next part 1. And in the end we will try to take the question from both of the lectures. Okay, thank you very much.